Okay, let's get started. Thank you again for joining us today. I'd like to take a moment to introduce myself and set the stage for today's webinar. My name is Sarah Thompson, and I'm the Technical Support Manager here at Response Biomedical, and I'm happy to be your host for today's session. For those of you who may not be familiar with us, Response Biomedical has been a key player in the diagnostic space since 1991. We are a privately held company, and we're proudly based in beautiful Vancouver, British Columbia. And all of our ramp technology is designed and manufactured right here in Canada. As the medical device company, we follow rigorous quality standards, including ISO 13485 and MDSAP. Our products are sold globally and include several FDA-cleared tests. Just a little bit about this webinar. It will run for about 40 minutes, followed by a 10-minute Q&A. At any time throughout the webinar, please feel free to submit your questions in the Q&A inbox, and we'll make sure to address as many of these questions during the Q&A segment. All right, and now on to the exciting part. Today we are thrilled to welcome back Dr. Brandi Gonzalez for a second webinar with us. Dr. Gonzalez is a doctor of clinical laboratory science with a wealth of experience and expertise. She holds multiple positions at Wellstar MCG Health in the Department of Pathology, including pathology utilization, specimen referral, pathology laboratory liaison, and she is also the Doctor of Clinical Laboratory Science Residency Program Director, among many other roles. We are so grateful to have her share insights with us today. And with that, what I will do is hand things over to you, Brandi.
All right. Okay. So thank you for that introduction. Today, we're going to talk about to NT-proBNP or not to NT-proBNP. That is our question. So NT-proBNP, of course, it's been around for a little while now. I remember when BNP first hit the market, as maybe some of you may. I'm probably giving away my age now. Shame on me. But it's been around for a while, and we're now trying to figure out, which one is better. Is BNP better? Is NT-proBNP better? When do you use it? And how should it be utilized? And what's the best case scenario? And so we're going to dive more into that today. So our objectives today is, well, we're going to differentiate between NT-proBNP versus BNP, list when is the NT-proBNP the preferred test, and then also describe how a rapid NT-proBNP result can actually drive quality patient care. So first, what is NT-proBNP? So fundamentally, this is a 76 amino acid hormone. And this molecule regulates blood pressure and fluid balance. It is released in response to heart stress and heart strain. And as you can see here, I really love this graphic. And let me see if I can find, is this it? Ah, there's the laser pointer. Love little laser. Come on, laser pointer. There's laser pointer. All right. So I love this little graphic here because it shows you how the pre-proBNP drops down into the proBNP and the signal peptide, and then the glycosylated proBNP. This molecule will then break down into the NT-proBNP and a glycosylated NT-proBNP. When you typically measure NT-proBNP, you're measuring this 76 amino acid piece over here. What then happens is that the body will break this glycosylated NT-proBNP down on this side into BNP as well, which is a 32 amino acid molecule. And so if everything, I wouldn't say normal because you only release this in response to heart stress or strain, but if you're releasing this hormone in a significant amount, the body releases all of this and you end up with BNP, glycosylated NT-proBNP, and NT-proBNP. And you would think, oh, okay, so it shouldn't matter which one you measure. Ideally, you would think that, but we don't live in a perfect world. So what's the difference between NT-proBNP and BNP? Well, first you got different half-lives. That NT-proBNP molecule has a half-life of 60 to 120 minutes. That smaller BNP molecule has a half-life of about 20 minutes. So when you're looking at changes within the body, that BNP is going to change much faster. When you're looking at the concentrations within the blood, those half-lives are going to be represented within that concentration as well. So you're going to have a higher concentration of your NT-proBNP in the blood than you are of your BNP. What the two biggest changes though between, or differences between the NT-proBNP and the BNP though, really have to do with medications and obesity. NT-proBNP is not affected by medications, but BNP is highly affected by this group of medications called ARNIs, or angiotensin receptor neprilysin inhibitors. Yeah, say that 3 times fast. We'll just say ARNIs. The one that's most commonly prescribed here in the US is Entresto. Now, overseas, you can also get Corlenor, and then there's some others that are in clinical trials. But the one that we see here in North America is Entresto. It is also the standard of care that is considered first line for congestive heart failure. So when you have a patient that is on this standard of care for congestive heart failure now, that Entresto, that medication is going to affect the BNP result. So you wonder, well, how does it affect the BNP result? Well, I'm going to back up one here. Come on, back up. Oh, come on, back up. All right. See this little cleavage right here? That medication prevents that cleavage. So you can't measure this BNP. It stops this BNP molecule from cleaving off this glycosylated NT-proBNP. So you can't measure it. The only thing you can measure reliably when a patient's taken an ANRI is the NT-proBNP. So when a patient is on Entresto, an ARNI, you have to use the NT-proBNP. Well, now that Entresto is the standard of considered care based off of guidelines, you have to use the NT-proBNP for monitoring those patients with congestive heart failure. The other reason is in morbidly obese patients. So studies started to track this difference in morbidly obese patients. And while there are changes in both the NT-proBNP and the BNP, that change is more pronounced in the BNP than it is in the NT-proBNP, especially once you get into the morbidly obese patients. Once you get to BMIs that are higher than 35, 40, higher than 45, that cleavage, that same cleavage mark that the ARNIs prevent, and those high morbidly obese, those high BMIs, that cleavage doesn't happen either. Now, research is still trying to figure out why. We don't know why. And we're still trying to figure out why it doesn't occur. We just know that it doesn't occur. So in those patients, even when you're trying to screen them for congestive heart failure, the BNP is going to show up falsely low. So you're trying to screen your patient for congestive heart failure in this patient with a BMI of 55, and you're not going to get an accurate reading. You're not going to get anywhere close to an accurate reading. Those are the patients you really need to use the NT-proBNP because they're not cleaving off that BNP molecule. So now that we've seen, where the NT-proBNP is actually the better molecule to use in those patients that are on those ARNIs, those patients that are morbidly obese, let's now look at why do we care? Well, because 1 in 5 patients are going to be diagnosed with heart failure and they're going to die within the first year that they get diagnosed. Additionally, 1 in 4 patients are going to get readmitted within the first 30 days of discharge from congestive heart failure inpatient admission. Now, those of you that are in the U.S., you are well aware of that, readmissions don't get paid. If you're outside of the U.S., that's not a thing, but in U.S. healthcare, it's a thing. If you get readmitted within 30 days of being discharged from the hospital, you don't get paid on that readmission. So it's something that we have to really be aware of. Heart failure often presents with very non-specific symptoms. So you really have to be sure that you are really looking at heart failure, because those symptoms can be confused for COPD, it can be confused for pneumonia, it can be confused for something else. Something you may even think, oh, I can treat this as an outpatient, when you really should be admitting that patient and reducing their fluid. And I like this meme, food won't fill that void in your heart. And I'm like, yeah, it kind of will. Always love that. All right, come on, slide. Work. So when we're looking at measuring NT-proBNP, generally, low levels, they're of no concern. When we're looking at cutoffs are going to vary. Anything that is less than 125, you're golden. You're green, you're good. The thing is that just because it's over 125 doesn't always mean that you're in the red. You're going to say, oh, it's bad. You always want to interpret your values within the clinical context of the patient. Always. Because just like any other lab test, what's going on with your patient, it's going to matter how you interpret your labs. Right, come on, Zoom. There we go. So first thing that can affect your NT-proBNP, is age. There's, some discussion on, should there be age-related values? And actually, I just realized that those values are all the same on there, and they should be different. We missed that in our editing. Oops. Knighton, oops, we missed that in our editing. Shame on us. So less than 50, there is some debate on whether or not there should be some differences in age specific reference ranges, because as we age, You do have more stress and strain on the heart, and you do produce more NT-proBNP and BNP. So whether you're looking at NT-proBNP or BNP, there is debate out there on whether or not you should have just strict cutoffs at whether it's 125 or whether it's 450, or whether you should have those difference in ages. And I want to say those ages are like 450, and I think it was 600, and I want to say it was 900. I want to say it was 900 for over 70. Because what you don't want to do is do full workups on patients that don't necessarily need it, just because they're throwing more NT-proBNP in their systems simply because they're getting older, and their heart is getting older, and those heart muscles are getting older. So there is that side of the debate. But then you've also got the side of the debate that says, well, you also don't want to miss a congestive heart failure, because you do have those patients that are, as you call, young 70-year-olds. So why should we adjust those ranges for older, but their bodies are actually quite young in retrospect, compared to other parts of the population? So there is a case to be made for either side. Really, you should look at your population, CLIA guidelines. I'm here in the US, so I'm going by CLIA guidelines, so that you should make reference ranges based off of your patient population. So look at the patients that you are serving, and see what what types of geriatric patients are you serving? Are you serving patients that are more of a nursing home? Then that may be a population that you may want to really consider having those age-adjusted reference ranges. Are you serving more of a younger community and much less of a geriatric community, or that geriatric community is very physically fit? You may not need those age-adjusted levels. So really look at what your patient population is when it comes to the age, and take that into consideration, because there is a debate over that. Also look at renal disease. Chronic kidney disease patients do have difficulty excreting both NT-proBNP and BNP. And as the kidney disease progresses, as you can see, those levels increase. So you can have high levels of NT-proBNP and BNP, and the patient not have congestive heart failure. They just have chronic kidney disease, or even be in full kidney failure. So you have to be very mindful of their kidney status when you are interpreting NT-proBNP levels. We see this a lot within my own institution. We're a transplant center, a kidney transplant center. So we have a lot of these patients with chronic kidney disease that are waiting on a transplant list. For those patients, we actually will measure their BUN and creatinine whenever we're doing an NT-proBNP. That way we're assessing what their kidney status is at the time that we're doing those NT-proBNPs. so we get an idea of where they're at, and then we can appropriately interpret that NT-proBNP and see what really is this a factor of the renal disease, or is this that they're truly going into congestive heart failure? Of course, that's not the only thing that we're using for congestive heart failure. We're using in full clinical context of the patient. But this is something that you really need to be aware of. You have to take the whole patient into account, and you don't want to go off just one number, go off the deep end, with a full workup, and not realize that that patient may just be in an exasperated chronic kidney disease state. All right.
Well, Brandi, just sorry to interject here.
Uh-huh.
Just go back, if you go back to the last slide.
Yeah, come on.
Yeah, so the typo there. So for less than 50 years for the NT-proBNP ranges, we had less than 450, and then 50 to 70 years was less than 900, and then over 70 years we had 1800. I'm not sure why it's showing otherwise. Sorry about that.
I knew the 900 was somewhere. So
Yeah.
it was the 50 to 70 was 900, and it was 1800 over the 70. Okay.
Yeah. Okay.
Yeah, I knew the 900 was somewhere. I just couldn't remember off the top of my head. Thank you for that.
You're welcome.
And we proofed these, and well,
Yeah.
we didn't proof them well enough. Oh, all right. So appropriate use of NT-proBNP. Well, first is in the diagnosis of heart failure. You want to make sure that you're differentiating between heart failure and other conditions that are similar. COPD, pneumonia, those are probably your two biggest ones. It could also be, things like costochondritis, something that anything with chest pain that is coming and going. You want to use NT-proBNP for guiding treatment. Levels of NT-proBNP will correlate with heart failure severity. So as I mentioned earlier, when patients that are on ARNIs, you have to use the NT-proBNP for monitoring that therapy. That is actually a standard in the guidelines now. And so you can use the NT-proBNP. The higher levels do generally indicate a poorer prognosis, non-responsiveness to therapy, things like that. Monitoring of heart failure, so serial measurements can help monitor the effectiveness of treatment. There's a guideline, I want to say it came out 2 years ago now. So for like inpatient stays, if you are checking at the beginning of the inpatient stay and then at the end of the inpatient stay, that can help with monitoring that inpatient effectiveness, and then serially as an outpatient for monitoring the outpatient effectiveness of that treatment. And then you can even use it for prediction of cardiovascular event risk. So if you've got a patient who currently does not have heart failure, but is showing some signs or symptoms. So they're having some lower leg edema, and they currently don't have heart failure. You run the NT-proBNP, and they're not quite at that level where you're concerned about heart failure, but it's not really low. It's getting kind of borderline. there's a risk there that they could be heading in that direction. Remember, the body is throwing this molecule off. It's measuring this molecule from somewhere. So that's, yes, it is negative, but that is, you want to look at trends over time. So not saying, oh, this is something I need to monitor all the time. It's okay. This is something that maybe next year, when they come back in for an annual, if they're still having that lower leg edema, we'll check it again and we'll see, have they progressed? Keep an eye that, oh, maybe if they show up 6 months from now and they now have another symptom. This is something for me to jot down, that I need to be aware that I need to start looking for more signs that they may be developing heart failure, or that I need to communicate to the patient that, you know what, you just be aware. If, maybe you want to be more aware of your blood pressure, maybe be more aware of chest pain, be more aware of things. I don't want to get you too concerned, but just be more aware. Maybe do some lifestyle changes now to help bring your risk down. Things like that. So turnaround time equals quality of care. And what I mean by that is the faster that you can get your test results, the faster you can get to diagnosis and a treatment. If you have delayed results, it takes longer. It takes longer to get to diagnosis. It takes longer to treatment. So if you can get a faster turnaround time, you get improved decision making. And there's a ton of research that showed that you can get a reduced length of stay, optimized workflow. If you can get reduced turnaround time in the emergency rooms, you have struck gold, because that improves your emergency room performance. You can get patients in and out of the ED, and you will be every hospital C-suite's golden child. They will love you forever. To get turnaround in the ED bed turnover, whew, they will love you. But the impact that you have on patient morbidity and mortality by reducing turnaround times of test results, that research has been utterly amazing. To save lives by reducing test turnaround time. What we've been able to accomplish in the laboratory industry over the last 30 to 40 years in just reducing the turnaround time of our tests, and how that effect has had on patient mortality alone, has been utterly amazing. And we continue to reduce the turnaround time. And of course, all of this leads to patient satisfaction, because at the end of the day, we're a service industry, and we've got to make our patients happy. That's the happier our patients are. And of course, they're happy when they get fast service, quality service, good service. We want good results, but they don't like to wait. We're in a give it to me now, kind of culture. We want everything now. We wanted everything yesterday. But the laboratory industry, we have really just made great strides on making everything fast. And I have to give it to Response Biomedical. They have developed this test that we use it in my lab, a ramp NT-proBNP on this ramp instrument. My staff loves it. we have this very instrument right here. We run the NT-proBNP test in my lab. We've been running it now, since 2019, I believe. Provides a rapid, accurate measurement NT-proBNP. It is standardized to Roche Alexis. So it's a standardized assay. It runs on individual cartridges. So you're not wasting big bulk reagents. It is modular, so you can stack them up. You can see here in the little picture here, we actually have modules stacked up. So it takes very small footprint, has a unidirectional information system, hooks up to your LIS. And I will say we've had one minor issue where one little module wasn't scanning a barcode and they replaced the module. And that's been the only issue that we've had since we went live with it years ago. It has been very, very nice. And like I said, my staff love it. Am I on screen? So I wanted to go through some examples of how you would use this test in different settings. And so this is an example in a critical access hospital. So you got a 54-year-old female that presents with palpitations and shortness of breath. She has a past medical history of type 2 diabetes, hypertension, and morbid obesity with a BMI of 54. Her troponin is negative, and her CBC and her CMP are within normal limits. So could this be anxiety? Could this be heart failure? You know, what do you do? You're in a critical access. What do you do with this? So if it's heart failure and you don't diagnose it, you could have subsequent progression, and you could have a potential upcoming myocardial infarction and death. So if you miss it, you could send her home to die. If you admit her and you don't have a workup, you've got no way to test for it, and she doesn't have it, then you just admitted her for no reason whatsoever. So this is a perfect example of where an NT-proBNP could be a factor in deciding whether or not to admit or discharge a patient in a critical access situation. You know, you've got a patient and you're not sure, you know, could I send this patient home or could I admit them? Now I know that I am really simplifying these case examples here. But this is just a simple example. You know, in an urgent care setting, you've got a 48-year-old male, new patient, presents with lower leg edema and fatigue. He also mentions that he's had off and on shortness of breath and occasional dizziness. You're unsure if you can manage him as an outpatient or if you need to admit him for CHF exacerbation. And you're in an urgent care. If you're going to admit him, you've got to call, you know, an ambulance to come get him. And, you know, so this could even be in a physician office for that matter. But, you know, this is a patient that clearly presents with all of the signs of congestive heart failure, but how severe is that congestive heart failure? Is this, very early? Is this very severe? Is this enough that you can start meds and treat outpatient, or is this a severe onset that you need to admit? Again, I know I am drastically simplifying a case here, but an NT-proBNP level can help with making that differentiation. And then an example of a tertiary care hospital, which is actually, this is my hospital. Your facility is using chemistry equipment whose manufacturer does not offer NT-proBNP on their test menu. And that's us. Our primary chemistry automation line manufacturer does not offer NT-proBNP on their automation line. The ramp NT-proBNP can help fill this test menu gap. And since ANRIs are now considered standard first-line treatment for congestive heart failure, we needed to fill that test menu gap. So we brought this test in on the ramp, and it perfectly fills in that gap that we needed to offer this test. So in conclusion, both the NT-proBNP and the BNP can be used for diagnosing and monitoring congestive heart failure. However, because of new treatment therapies that are out there, specifically the ARNIs, the NT-proBNP is the only one that can be used for monitoring ARNI therapy. Providing rapid results improves patient care and outcomes, and so providing a rapid result like those provided on the ramp NT-proBNP can help facilities and clinicians by providing accurate and rapid NT-proBNP results, and this provides for better patient outcomes and better patient care.
Okay, that's great. Thank you, Brandi. That was super informative. We have some questions from the audience. I'll start off here. How can NT-proBNP results be used to triage patients in the ED and outpatient care setting?
So I gave an example of the one in the urgent care where someone comes in and you're not really sure if you need to send that patient on, if you need to admit that patient. It's that's really where the test can help with that fine line where you've got that patient that I'm not really sure. I could make a case to go either way, to whether I admit or I send them home. The NT-proBNP can be that deciding factor. It's not for the patient that is like super clinically stressed that you've got to admit. If you've got a patient that's having trouble breathing and it's you're going to run it as a baseline, but you're going to admit them anyway. Okay.
Yeah.
But if you've got that patient that you're like, oh, maybe I could send them home, maybe I could admit them, I'm kind of teetering here what to do. That's where having that rapid NT-proBNP is really useful for being that deciding factor on whether should I admit or should I send them home? Can I manage this outpatient, or does this patient really need to be admitted? And that's where it's it's really useful, especially being rapid.
Great, thank you. Next question. How can NT-proBNP results help remote patients, such as telehealth patients or those who have already been discharged?
Ooh, great question. So, we actually have a program here where uh, we monitor our patients that have been discharged. You know, I mentioned how in the US there is this readmissions penalty that we, you know, if patients get readmitted within 30 days, we don't get paid for a readmission. So about 8, almost 9 months ago, we instituted a new program where if a patient gets discharged with congestive heart failure, we actually send a nurse practitioner out once a week to those patients in their homes, and they get their vitals, their weight, but they also draw an NT-proBNP, and they bring it back to the facility, and we run it on our ramp, and it's a monitoring to, because if we can adjust their meds outpatient and keep them out of the hospital and do that remotely, it is so much better. It is better for the patient. They recover much better at home, and it keeps, I mean, we don't get paid if they come back, so it's better for the hospital, and it's better patient care. You have better patient satisfaction if they don't come back into the hospital as well.
Definitely.
Yep.
Okay, thank you. Is there a way of normalizing adjusting NT-proBNP level in renal patients based on creatinine clearance or GFR?
Mm. Um, you know, there might be a way in your EMR to do that. That would be interesting. You would probably have to build it as like an order set, so that every time that you got an NT-proBNP, you got a creatinine and an EGFR, and it would then normalize it. We don't have that automatic. That is interesting. Ooh, I will have to take that back to my IT team. Ideas.
That's a
Wheels
good
are
question.
spinning. Ooh, ooh, ooh.
So much excitement.
I know. Ideas. Right.
Okay, I've got another one for you.
Uh-huh.
Are NT-proBNP values affected by chemotherapy?
Not that I am aware of. But would definitely have to look that up. I am not aware of it being affected by chemo, but I have not researched that much into it.
Okay. Great. Brandi, thank you so much for taking time to answer questions. Today's session was really, truly informative, and it was an absolute pleasure to welcome you back here. I'm already looking forward to tuning into your third webinar with us. And a big thank you to everyone who tuned in. We appreciate you all being here and hope you all have a great day.
Thank you so much.
Thank you.